Good morning or good afternoon. My name is Tracy Cook, and I am with Sachs Healthcare Communications. Before I introduce our moderator and speaker, on behalf of Medtronic and Sachs Communications, we want to thank all frontline workers in our audience for your commitment and passion in helping us all through this very difficult time. We are truly indebted to you all. For today's session, you do have the option for translation in either Spanish or Portuguese. There are two steps. Step one, please open a Chrome browser and go to the website that we've pushed through the questions box. Next, type the password #webinar and then select either Spanish or Portuguese. Step two, you do need to mute the GoToWebinar toolbar. Please click on the GoToWebinar tab on the top of your browser and right-click on the GoToWebinar tab at the top and choose Mute Site. You should now only be able to listen to the translated version. For today's session, to ask a question, please type them into the questions box. Our speaker will answer as many as possible at the end of the webinar. Our moderator is Fernando Yuste. Fernando Yuste is a Senior Global Principal Training and Education Specialist at Medtronic. He has over 20 years of international experience in the medical device industry with positions ranging from management, sales and marketing, product development, clinical affairs, and business development. Dr. Yuste holds a PhD degree in physics from the University of Madrid and an MBA marketing specialty from ESADE Business School. Fernando, welcome.
Thank you very much, Tracy, for this kind introduction. Good morning, good afternoon, good evening, everybody. Welcome to our webinar on opioid-free anesthesia. Today, we have with us Dr. Barry Friedberg. He's an early technology adapter, a board-certified anesthesiologist who practiced the last 26 of his 41-year clinical career in office-based anesthesia. He's the author and editor of the 2007 Cambridge University Press textbook, Anesthesia in Cosmetic Surgery, which was translated to Portuguese and Mandarin. His textbook was the first to feature a process EEG monitor on the cover, as well as first to enumerate process EEG measure levels of sedation and anesthesia. His propofol then ketamine paradigm was adapted by mobile forward units of the US military for anesthetizing soldiers with non-penetrating wounds. Freed of the need for anesthesia machines and cumbersome, thanks to Dr. Friedberg's contribution, received the US Congressional Award. The US military also wrote a chapter in his textbook entitled Propofol Ketamine Beyond Cosmetic Surgery, Implications for Military Medicine and Mass Casualty Anesthesia. Dr. Friedberg has published many other book chapters, articles, and letters to the editor. His articles have been subsequently cited in 192 later articles and 50 anesthesia textbook chapters, including Miller's Anesthesia 2010 and 15 editions. He served as an adjunct faculty at both the University of Southern California and University of California, Irvine. He's a well-traveled national and international lecturer, and most recently he was in Abu Dhabi and Dubai. Next slide, please. Faculty disclosure is that Dr. Friedberg has been in control of these contents, and all this presentation has been created by him, although he's receiving funding from Covidian. Next slide, please. Continuing education for physicians, CME, is being accredited today for 1 hour by the Accreditation Council for Continuing Medical Education. Next slide. We also give CE accreditation for nurses and respiratory therapists, 1 hour too, and a link to obtain these CE credits will be available at the end of this webinar. With that, please join me welcome Dr. Barry Friedberg.
Thank you very much for that kind introduction, Fernando. Today's learning objectives for opioid-free anesthesia include discussing incremental propofol induction, describe ketamine side effect avoidance, and discussion of how to differentiate between purposeful and non-purposeful patient movement. The problem we have in office-based anesthesia is patients taking too long to wake up, patients waking up in pain, and patients waking up with nausea and vomiting. Why did it take too long to wake up? Well, they either got too much or the wrong medication. Why do they have post-op pain? Because they had pain during surgery. There's a fundamental disconnect between what patients most value to avoid and what anesthesia providers most value. Both pain and nausea and vomiting are remain problems, and both can contribute to unexpected hospital admission after day surgery, and both concerns are addressed with opioid-free anesthesia. This was a really interesting meta-analysis of 23 studies covering 1,304 patients. This is Frauenknecht and his comrades, and they came to the interesting conclusion that opioids don't prevent postoperative pain, but they do increase postoperative nausea and vomiting. So the point here is that although it's a 100-plus-year tradition of giving opioids, we're not really blocking pain during surgery. The subtitle of the talk, of course, is Ketamine is my patient's best friend. So why not just give deeper anesthesia? Lichter and company told us that pain goes to the spinal cord and the brain even during deep general anesthesia. Friedberg's triad is a pathway to opioid-free anesthesia. Very simply, the 9 words I hope history will be kind enough to remember me are measure the pain, preempt the pain, emetic drugs abstain. Number 1, measuring the brain. We have an interesting problem in sedation. Not every patient under sedation is as obvious as the chicken with the head cut off. Clearly, the chicken is moving without any input from the brain. When we have a patient under sedation on the operating table, it's a little difficult to figure out what is purposeful versus non-purposeful. So all patient movement is not equal. And this is part of the role that processed EEG monitoring creates. Actually, it wasn't until I added the processed EEG that I was able to sort this difference out. The elephantine question is, how do we determine the dose without direct measurement of cortical response? And you see the 5 blind anesthesiologists trying to define that dose. But as the sage Lord Kelvin said a long time ago, if you cannot measure it, you cannot improve it. This is a very interesting study in 1999. Karen Domino and company looked at a closed claim analysis of patients who had awareness under anesthesia with recall. And at least 50% of the patients had no changes in vital signs, that is, no heart rate or blood pressure changes with which to alert their anesthesiologists. So clearly the impact of this, the import of this study is that we really cannot rely on heart rate and blood pressure changes to tell us what's going on in the patient's cortex. On the left, you see what happens when we give average doses. Basically, we're playing the bell curve odds. And on the top, you see average patients. There are no average patients, but most people we anesthetize are in the 80% range. There's some people at 10% who are very, very sensitive, and some people on the right who are very, very resistant. On the right is my processed EEG monitor, and I want you to notice that there are not 1 but 2 trends, and we're going to talk about these trends. The lower trend is the EMG, the electromyogram of the patient's facial frontalis muscle. This is as real-time a signal as the EKG of the cardiac muscle and plays a critical role in 2 functions we'll talk about later. We're going to show you a video of what happens when you directly measure and find those people who are at the very far end of extremely sensitive. This video starts just after induction. The BIS is running 54 with baseline EMG, so it's very hard to see the red trace because it's traveling along the axis. Most of my patients take 25 to 50 micrograms per kilogram per minute of propofol to achieve a BIS value of 60 to 75 with baseline EMG. This lady is taking less than 1/10 of my average dose. So you see this and you look at this, and if this was the only time this happened, I would say, well, who knows? But this was one of several patients I found who are extremely sensitive. So we're ready to show the video now, please. Can we show the video, please? I guess we're not going to get the video. At any rate, the interesting thing about this clip is that it takes about 2 minutes to get the patient off to sleep, but yet you see no changes in the pulse oximeter tone. We're going to try again for the video. Yes? Okay. All right. Well, we're not seeing the video, but I'll talk about it anyway. We're not seeing the video.
The video is working right now. It may be behind another screen on your desktop.
Ah, okay, thank you.
For those in our audience that say that it's a little soft, just turn up your computer speakers. We're almost done this video, Dr. Freeberg, if you want to talk about it. And then now I'm going to bring you back to your PowerPoint slide.
It's very disconcerting because I can't see the video.
Okay, we're back on the PowerPoint.
All right. The choice of cortical monitor is important, but the idea isn't which cortical monitor. The idea is if you cannot measure it, you cannot improve it. So there is BIS, there is SedLine, there is Entropy. I must say that I had no experience with either one of them. All of my 20-year experience using process EEG is with the bispectral index, and I want to give you an idea of why. In 1997, when I first started using it, there were no other monitors on the field. The device is basically the IBM or Kleenex of the field. It was the first available. It's also the most validated in publications, over 3,500 papers. But more importantly, or just as importantly, there are no papers claiming that the newer monitors are better than the BIS. There is one paper at least claiming equality. So my entire professional experience, 20 years with processed EEG, is with the bispectral index monitor. Here are the numbers that we talk about. Now, I only include these 4 ranges, but in fact, for purposes of interventional radiology, one could easily titrate the propofol to 78 to 82 and have a responsive patient. I'm not interested in having patients responsive under surgery in the office setting, so I'm titrating to moderate to deep sedation, 60 to 78. Hypnosis compatible with general anesthesia is 40 to 60, and overmedication is less than 40. But none of these values are really accurate without baseline EMG. Moving along. So why is it people don't use BIS more often? Well, in the upper left-hand corner is what I was using for the first year. And when we talk about processed EEG, it means it takes time to process. So that 43 represents where this patient's hypnotic level was 15 to 30 seconds ago. And it's very, very hard in anesthesia to determine what you're about to do next when you're looking at history or looking in the rearview mirror. The lower left-hand corner shows you the BIS trend with the real-time EMG, I'm sorry. And this allows you to look ahead about what's about to happen. EMG spike is very important because it's telling you the patient is about to wake up, and the proper response is to respond to that spike with the same alacrity that one would respond to heart rate or blood pressure. Titrate increased propofol to get the EMG back to baseline. So basically, the incremental induction involves a short amount of time. We maintain airway spontaneous ventilation. There's no SpO2 change and no need to support the airway. This EMG, this clip was seen on YouTube over 180,000 times. Principles of airway management: if it isn't broken, don't fix it. There's no shame in keeping the patient breathing. And in the office setting, the last thing you want to have is a can't ventilate, can't intubate scenario. These are the muscles involved. It's not just the genioglossus, but when you're doing sedation, you have temporalis, masseter, orbicularis, oris. And again, this keeps trouble away. The induction takes about 2 minutes, and giving propofol this way is somewhat analogous to getting a Diprivan, a dopamine level, to treat hypotension. You don't give a bolus of dopamine to start with. you start low and you increase, titrate to the desired effect. We have the second video, please.
Certainly, I'm going to show the second video right now. Again, if people are having issues, just turn up your computer speakers. Dr. Freeberg, I'll let you know if it's not playing, but currently the first one played fine on my computer. Thank you.
Wonderful, wonderful.
Here is that the red area, EMG, will start to decrease before the yellow, the biz monitor. And here's Dr. Lin.
I didn't realize you're so tall.
Yeah.
Especially when like standing.
Come on, new person, right? Okay, 'cause I'm going right now. I can feel it.
Hopefully
relax.
it feels pleasant.
It feels pleasant. This is like my ideal way to die, but I mean.
Well, we tend not to do
old
that.
and I'm like 106, you know?
Yeah.
I want my dog by my side though.
Mm-hmm.
What kind do you have?
A Roddy. Well, I'm a daughter too, but. So. Alright, here we go.
So this young lady is a nice young lady.
Will I be twitching?
No, no twitching.
I might be gassy because I didn't eat, but.
Yeah, that's okay. We don't charge extra for gassiness.
I'm feeling a little drunk.
Mm-hmm. It's pleasant though, isn't it?
It's a drunk feeling.
Yeah. So
I might say, I'm sorry staff, but I might say shit that I don't.
You wouldn't say.
Just don't worry, you know, I haven't had food since 10, so.
Yes.
This is a
Fortunately,
nice
this little
feeling.
video doesn't have audio in it. It's just the video, so
Please don't mind my dry mouth.
it's okay.
This is a nice feeling.
Isn't that nice? Now you know why everybody likes Dr. Freeberg.
And when I get home, can I eat?
Yes,
How immediate?
immediately.
Okay, because I made some good porridge.
Mm-hmm.
If I wake up and marry an anesthesiologist,
Mm-hmm.
I can eat, right?
Yep,
How many,
you can.
how many chances to the
Mm-hmm.
how many
Put your arm right here.
I spent
Okay. Make sure we get that.
I got
We're all
both.
set to go.
I got her and I got the biz
Great.
in frame.
Super. Perfect. That's great. You can stop now.
Thank you, Dr. Friedberg. We just finished watching the second video and we'll be back to you.
Okay, the real purpose, the main thrust of the incremental propofol induction is to create a stable level of propofol in the brain to prevent ketamine side effects, most importantly, ketamine hallucinations, which is the main reason people are terrified to use ketamine. I've not had any hallucinatory experiences in the 26 years and more than 6,000 patients. So the principle that I evolved and started working on in 1992 is a very sound one. First, have the patient sleep with a smooth level of propofol in their brain, and you have no side effects from ketamine. Now we're going to talk about preempting the pain, the second part of Friedberg's triad. And the sad truth is that once the brain is anesthetized, it can't tell the difference between a mugger's knife and the surgeon's scalpel. All it knows when that negative information occurs after the breach of the boundary between the outside world of danger and the protected world of self, the skin, after the skin is breached, the brain cries out, invasion, invasion, danger, danger. And so fundamentally, the concept of preemptive analgesia is that the brain cannot process information it doesn't receive. And how we do that is by giving 50 milligrams of ketamine 2 to 5 minutes before stimulation. In the cosmetic world, it is the stimulation of multiple local anesthetic injections. In the non-cosmetic world, it may be skin incision or trocar punctures for endoscopic procedures. The point is, if you do not saturate those NMDA receptors with that 50 milligrams of ketamine, my picture of what goes on in the brain is boom. And it's very, very important. Once you take this situation away, everything you know, everything I knew about what patients look like post-operatively changes in a very dramatic fashion. Again, I remind you that the brain simply can't process information it doesn't receive. You see the arrow there where nociception or pain signals don't reach the brain, the cortex. Well, there's not much to go on. At any rate, NMDA receptor saturation is defined by no EMG spike with stimulation. So when my cosmetic surgeons start injecting local, or when your surgeons gave a scalpel incision or trocar puncture and you're trending along and you see the EMG remains at baseline, you now have objective evidence that you have created NMDA receptor saturation and the beginning of preemptive analgesia, opioid-free preemptive analgesia. So the ASA told us that arousal, which is what that EMG spike is showing us, precedes nociception. There is some controversy using ketamine with the bispectral index. Dr. Sengupta and company in 2011 published that when they gave a 0.5 milligram per kilogram of ketamine, the BIS elevated, and that was what they felt was a stable level of propofol. However, when I was measuring the CNS propofol response with the processed EEG, 50 milligrams of ketamine produced no change, and I published that in 1999. It was confirmed by a later publication by Nonaka in 2012. So there really is no controversy using 50 milligrams of ketamine in the context in which I've described. So basically, how do we provide objective evidence of adequate analgesia with sedation? Well, the problem is that our cosmetic surgeons, plastic surgeons, believe when they see vasoconstriction, that means the patient is numb. And this technology allowed me to disabuse my surgeons of that notion. If the patient is moving, and where you see the arrow, there is absolutely no EMG response, and the patient is within 60 to 75, this is objective reassurance that the patient is asleep, that the movement has nothing to do whatsoever with awareness and recall. So basically, vasoconstriction does not equal analgesia, adequate analgesia, and the re-injection with this type of movement with no EMG spike obliterates 98 to 99% of patient movement. So what you want to have is an operating room that isn't like the surgeon is arguing that the patient is too light and the anesthesiologist is saying more local, like the famous beer commercial where they went round and round. This one says it tastes great, the other one says less filling. You use your EMG and real-time EMG to facilitate adequate local analgesia for a sedated patient, because numb patients generally don't move. So what about the rest of us, Dr. Freeberg? Many of us don't give cosmetic surgery anesthesia. We want to go back to the boundary between the outside world of danger and the protected world of self. The skin is the largest organ of the body. The skin has the most number of nerves, and the skin is the defense line. So you may not violate the boundary without NMDA receptor saturation if you want to avoid problems. Basically, when the red goes up, the white goes in. That's as simple as I can make it, because that's how I think of it. In the operating room, I respond to those EMG spikes, those red spikes, every bit as quickly as I used to respond to heart rate and blood pressure changes. The problem is that to this day, they're still teaching that ketamine causes hypertension, tachycardia, and most distressing hallucinations. This is true when ketamine is given as a solo agent. It is true if it's given when it is not a smooth level or a steady, stable level of brain propofol level. I published this back in 1993, that hypnotic doses of propofol block ketamine induced hallucinations, but it's tough to convince the rest of the world that this is the case, but that's been my experience over nearly 3 decades. Ketamine, the dose and timing are both critical. To get opioid-free preemptive analgesia success, you have to saturate those NMDA receptors. A 0.5 milligram per kilogram is great if most of your patients are 100 kilograms or more. Most of my patients were 60 to 80 kilogram, with some exceptions that we'll talk about in a little bit. The timing is also important because you need at least 2 circulation times, or about 2 to 5 minutes, before you stimulate the patient, whether that's with multiple local anesthetic injections in my world, skin incisions, or trocar punctures in the medically indicated surgery world. So what about internal pain fibers? There are internal pain fibers, of course, but they're exponentially fewer than the skin, and the skin fibers are most critical to patient outcomes. Still, we have a study of 120 patients that was an open cholecystectomy, one of the most stimulating surgeries, where they gave pre-incision IV or subcutaneous ketamine and noted a dramatic decrease in post-op pain for the first 24 hours. There's a warning when you use ketamine. I just published this recently. The ketamine laryngospasm is different because there's no crowing, and there's no crowing because the cord slams shut. The only warning you have is a prodrome of a cough or a sneeze. Again, I respond to that with great alacrity, giving 1 milligram per pound of IV lidocaine. The problem is the traditional jaw thrust and positive pressure ventilation simply fails to adequately deal with this issue. Now we want to talk a little bit about emetic drugs. And of course, we want to define emetic drugs. These are all our friends, especially fentanyl. We're all familiar with morphine, Demerol, pethidine, hydromorphone, alfentanil, sufentanil, and remifentanil. The interesting thing that Dr. Apfel, Christian Apfel, talked about in his chapter in Miller's Anesthesia, he said specifically, as long as the metagenics are part of the anesthetic regimen, the use of antiemetics is of a limited utility. I thought this was an astounding thing from a guy who was making his living evaluating antiemetics. But for those of you who don't know who Christian Apfel is, he's one of those rare anesthesiologists who published his 4 risks for post-op nausea and vomiting in the illustrious New England Journal of Medicine. Those 4 risk factors are non-smoking females with post-operative nausea and vomiting history or motion sickness history, having a metagenic surgery, which is not infrequently defined as cosmetic surgery, ENT surgery, intra-abdominal surgery. So what happens when you give opioids to these type of patients? It's like throwing a match into gasoline. It's not good, and patients don't do well with it. What are opioid-related adverse drug effects? I'm sure we're all familiar with them, but I'm sure most of us are not familiar with what the consequences of nausea and vomiting, respiratory depression, sedation, post-op brain fog, ileus, constipation are. If you have even one of these, this study told you what the price of having those are. There's a 55% increased length of stay, 47% increased higher care costs, 36% increased 30-day readmission rate, and 3.4 times higher mortality risk. This is the price of opioid-inclusive anesthesia, and certainly appears to me a very good reason to use opioid-free anesthesia. This was a study that came out in 2013. So why are we so delinquent about patients' number 1 concern? Vomiting. Well, the sad truth is they don't vomit on the operating table. We take them to a recovery room where somebody else has to deal with the problem. That's not the case in office-based anesthesia. There's no place to go because frequently the operating room in a small office facility is admitting, surgery, and recovery. So there's no place to hide if your patients are throwing up after surgery, and my patients mercifully didn't. The 5-year paper we're going to talk about here in a second. This is Christian Apfel in his chapter in both 2010 and 2015, Miller's Anesthesia. He cites my 5-year review. Now, this was all done pre-processed EEG monitoring. Of those 1,264 patients, only 7 succeeded in throwing up. And when I talked to each one of them, they said it wasn't so bad, it was once and done. Whereas opioid-related post-op nausea and vomiting is over and over and over again. The other really exquisite thing about this citation is that he compared my 0.6% post-op nausea and vomiting to the legendary Paul White's 7%. But I figure anytime you're being favorably compared to Paul White is a pretty nice endorsement. So thank you very much, Dr. Apfel. Surgeon preparation is very different than giving anesthesia in an operating room in a hospital or a surgery center because you're in a much more remote setting, which increases the incentive for the surgeon to cooperate. This thing works very much nicer if the surgeon will re-inject local when the patient moves, despite having a blanched field. So you have to be able to differentiate patient movement, whether it's coming from the spinal cord or the cortical origin, which is a great function of the EMG and the processed EMG. EEG of the BIS monitor. So the correct therapeutic maneuver is to give more local and not ask for deeper anesthesia. And when all these things happen, you get tremendously better outcomes. And they're dramatically better. It's not something that requires a level 1 RCT to figure out the difference. I want to talk a little bit about one of the biggest cases we've done. I've done about 800 or so abdominoplasties in my career in office-based anesthesia. And abdominoplasty is the reflection of the dissection of the abdominal wall, skin, and subcutaneous tissue from the pubis all the way up to the xiphoid. And the principal part of the surgery is the imbrication of the rectus muscle sheath. Now, the reason I make a point about the sheath is that we're not sewing muscle together. This does not require paralysis to do this, although that was my teaching and my belief until I started working in the office and actually saw what was being done. There's a huge difference between pulling a couple of centimeters together of the sheath and putting a big retractor in, as you see below, to hold the rectus sheath apart while you do an intraperitoneal procedure. Abdominoplasty is an extraperitoneal procedure. It's a large dissection, but it is extraperitoneal. So before we show the next video, I want to remind you that this video was shot in 2009 before end-tidal CO2 became a standard of care. Now that it's a standard of care, I use a two-pronged nasal cannula, which is very common, you see, but instead of sending oxygen through both cannula, I measure the end-tidal CO2 through one limb and give a liter of oxygen per minute through the other. One of the descriptions I made years ago was room air spontaneous ventilation, or RASV, because the amount of respiratory depression is minimal. You're titrating to both cortical effect with your processed EEG and brainstem effect with your pulse oximeter. So we are ready to show video number 3. Just a second, I forgot. Also, the thing that you'll see is that the patient's sat drops a little bit, and with a little lift to the chin, it comes back up. This sort of reinforces the idea that there is minimal respiratory depression. Okay, let's roll the video, please.
Thank you, Dr. Friedberg. I'm just going to roll the video right now.
Gonna flip.
We have some pictures, actual live pictures this afternoon.
You like that camera?
I love it.
Is it an HD one?
Yep.
And thank you, Dr. Friedberg. We're back to you now.
Okay, one of the papers that I wrote a long time ago, about 2004, which I love to talk about, is called Minimally Invasive Anesthesia for Minimally Invasive Surgery. And I was trying to convince one of my colleagues of the virtue of using fewer medications instead of more. And he said, Barry, that's great, but the more drugs I give, the better I feel. And I kept thinking to myself, but what about the patient? And part of the reason we give lots of drugs in anesthesia is we don't know what's going on in the patient's cortex. One of the huge values of the processed EEG with real-time EMG is it takes away the fear and anxiety of what's going on in that patient's brain. It is a tremendous source, that information is a tremendous source of tranquility to me in the office setting. And it's a tremendous boredom killer too, because it rivets your attention, because the number of times you presume a certain patient will take more or less medication is confounded by the fact of direct patient measurement. I never ceased to be amazed the number of times I was convinced I would need an LMA or something else, or the patient was going to be a huge drug resistance, and they weren't based on measurement. So measurement really is powerful. The next case, the next video we're going to show is the same patient that you just saw having the abdominoplasty. This is less than 5 minutes after we turned off the propofol. And I want you to pay particular attention to the sound of her voice and her peaceful facial expression after a 4-hour abdominoplasty. Okay, so let's go to there. The emergence is really very typical of what my patients experience.
Thank you. I'm playing it now.
Okay, Lily, what'd you think about the experience? Was it pretty good?
Yes.
Did you remember anything? You've been asleep for 4 hours.
No.
Don't remember a thing. No bad dreams.
No.
Wonderful. So that was really a good experience then, huh?
Yeah.
You like Dr. Lin, don't you?
Yes.
He's the best. And
Yes.
Anais held your hand, and I held your other hand, and you had a good snooze.
Cool.
And no dreams.
No.
Fantastic. All right, well, speedy recovery.
Thank you, and we're back to you, Dr. Freeberg.
Okay. So how do we do opioid-free anesthesia? I always start every case with 0.2 milligrams IV glycopyrrolate to combat the secretions that the ketamine will not infrequently create. Secretions are a notorious cause of precipitating laryngospasm, so we don't want to have to deal with that. Then we're going to give incremental propofol induction and maintenance, again, to make sure we don't have any ketamine side effects, especially no hallucinations. We want to maintain a BIS value between 60 and 75, which is moderate to deep sedation, with the caveat that we absolutely want that EMG to be trending right along the horizontal axis, baseline EMG. And then 2 to 5 minutes pre-stimulation, give 50 milligrams of IV ketamine independent of body weight. People always ask me about that, and I say, I've used the same dose in patients with between 30 kilograms and 145 kilograms. So I'm convinced in my mind that the effective NMDA saturation dose is independent of body weight. Not true for the propofol, but very much true for the unique compound of ketamine. And then before we stimulate the patient, either with multiple local anesthetic injections, skin incisions, or trocar punctures, we want to infiltrate the subcutaneous tissue with lidocaine and epinephrine. And before we close the case, we want to splash some bupivacaine in the wound. It's not necessary to inject the bupivacaine because it is bound to proteins quickly and doesn't need injections. So what happened in this little story of mine that's been going on for quite some time now, more than 6,000 patients? I would tell you that the first 6 years were not done with the benefit of processed EEG and real-time EMG, but it became a whole lot easier and a whole lot better when I could educate my surgeons that they needed to just re-inject more local anesthesia when the patient moved under sedation under very specific circumstances. Again, that's with the BIS in 60 to 45 range with baseline EMG. These are all office-based cosmetic surgery patients. There was not a single hospital admission for either pain or post-op nausea and vomiting. All these patients were discharged to home within the usual hour or less. There were no opioid addicts, no overdose deaths, and it was just a remarkable experience that people who followed my pathway have emulated. One of my favorite people is an early technology adopter in Hull, England, a guy named, an anesthetist named Chris Pollack, who said, really, the problem is very simple, Barry. If you want people to stop throwing up, stop giving them drugs to make them sick to their stomach. At any rate, I'm pretty proud of these outcomes. I've published them extensively, and every time I get an opportunity like today to share my story, I'm thrilled to death, and I hope you found me to be very enthusiastic about this. It's quite remarkable. Anyway, people like to know about adjuvants. In the days when propofol was expensive and proprietary. I was giving 0.2 milligram of clonidine 30 to 45 minutes preoperatively, and I thought I was doing a wonderful thing saving propofol, but when the propofol became generic and relatively inexpensive, I stopped giving the clonidine to avoid the occasional postural hypotension. Strangely enough, I saw no difference in propofol use, so I think the essence of the story is you have to measure what you're medicating, and using a processed EEG is a fantastic thing. Also, when rofecoxib or Vioxx was on the market, I was giving 50 milligrams of that preoperatively, thinking I was doing good. I thought the patients were doing better. The drug then came off the market, and lo and behold, there was no difference in outcome. Pretty much the same thing for the acetaminophen or Tylenol. My plastic surgeons would not sit still for the cost of the intravenous preparation. I tried giving it orally, and then I stopped. It didn't see any difference. Magnesium sulfate was the same story when that was quite a rage, 2 grams IV early. When I stopped giving it, didn't seem to be any difference. About 12 years ago, when I had my own hip replaced, I insisted on having 10 milligrams of dexamethasone preoperatively, in addition to my 50 milligrams of ketamine. And so that's something I give, and I think it's doing better. But I guess if I took it away, it probably would be the same story as the clonidine and the rofecoxib and acetaminophen and mag sulfate. I also give 15 to 30 milligrams of IV ketorolac, 30 to 45 minutes before closure, and that seems to help. I admit straight away that I've had no experience with IV lidocaine, dexmedetomidine, or liposomal bupivacaine, known as Exparel. So that's pretty much my story. Friedberg's triad, I remind you, is the pathway to opioid-free anesthesia, and opioid-free anesthesia is the pathway to dramatically better patient outcomes, especially in the areas of pain and post-op nausea and vomiting. What forest? I only see trees. Well, actually, one tree is anesthesia awareness. Anesthesia with awareness, people like to talk about. I will remind you that it is only the risk of PTSD. There are no reported deaths, not a single reported deaths with anesthesia awareness with recall. That's not true for the forest of overmedication. Overmedication is a natural consequence of failing to measure the organ we medicate. And Dr. Lee et al. In his mortality study showed us that 1 patient a day in the United States, 1 patient every day dies from overmedication. Now that's not a whole lot of patients, 365 patients out of 50 million a year. But if one of those patients happens to be a parent, a loved parent, a spouse, a child, that's a pretty disastrous outcome to deal with, especially when it's completely avoidable. So because of all these things, I self-funded a nonprofit Goldilocks Anesthesia Foundation, and making biz with real-time EMG monitoring a standard 21st century standard of care is the only goal of my foundation. So I thank you all very much for listening. I'm sure there's going to be lots of interesting questions. The references that are here, most of my papers can be accessed on the open access research guide. The videos you've seen can be found on my YouTube channel. So thank you very much. Let's see, Fernando, I'll turn it back to you.
Absolutely. Thank you very much for a great presentation, Dr. Friedberg. Before we start the Q&A question, we have a number of wonderful questions here that I'm going to start bringing in. I want to remind everybody that this was a continuing education accredited event for doctors, nurses, and respiratory therapists. And to obtain your accreditation, you need to go to www.saxetesting.com/init and then another slash. Sorry, it's not exactly well written there. And you will be able to register there and get your certificate, download your certificate after you complete an evaluation. The support of this activity has been provided by Medtronic. Finally, we will say that this event has been recorded and will be available on demand on the website of SACSE Education in Healthcare Education, which is initiatives-patientsafety.org. This on-demand version will also be accredited for physicians, nurses, and RTs. With that, I'm going to start the Q&A part of this session. We have 50 minutes, which is great, and we have a lot of good questions here. I'm going to start with a question from Union that says, if we use ketamine or nitric oxide, N2O, as part of anesthesia, would the process EEG system still be used the same way?
That's an excellent question, and unfortunately, I have no clinical experience with which to give you a good answer. Nitrous oxide is an expensive process and not readily found in the third world, as I learned many years ago as a student. So I'm not sure what the upside would be to add more drugs when the few drugs we have are doing such a fantastic job. Again, it's a very good question, but I unfortunately have no personal clinical experience to give you an answer.
The next question we have is, under deep neuromuscular blockade, spikes remain visible on EMG, but much smaller EMG spikes are comparable to the increased sympathetic activity visible on ANI or NOL. Any comment to that statement?
Well, again, I can only share with you what my experience has been. All of my patients for the last 26 years have been breathing spontaneously without neuromuscular block. I get varying conflicting answers from my colleagues who do use neuromuscular block. Some say the EMG persists and they're useful, and others say they're not that high enough gain. So from a personal point of view, my experience is that I can't tell you what would happen because I've never been there.
Somebody's asking here an interesting question. Have you ever used or have heard of the nociception monitors to check that your patient actually doesn't feel nociception in the interpretive period?
That's another excellent question. This is relatively new technology on the market. I have not really seen many papers about it. The only thing I do know is that the sensors are on the body. At least one gentleman told me that the sensors are on the body, not on the head. And so since I know before the patient is about to have pain by the signal of the EMG is incipient arousal. So if you deal with incipient arousal, you don't have nociception. So I don't think I would have any use for one of those monitors in my practice, and I have never used one.
Well, we've been friends for a while, so I will say that I'm going to disagree, and I'm going to bring Lord Kelvin here, Barry, because I believe that this would be a complementary way to confirm that what you're doing is working. So maybe we have to have a separate conversation here, but I believe that there is a use of the nociceptive monitor in your practice. Next question is, okay, somebody is telling you, would it not be better to give ketamine or other sympathetic blockers instead of propofol when the EMG spikes come up?
I'm sorry, I didn't understand the question. You say giving ketamine when the EMG is arousal?
Yes.
I mean, the EMG spikes come up. It never crossed my mind to give ketamine under those circumstances. The indications I have for giving more ketamine beyond the initial dose is if the surgeon is going to inject a virgin field, that means the patient will move if they don't have more ketamine at that point. And the other caveat, the two caveats, is when I looked at 1,000 patients of mine, I found that 80% of those cases were done with 1 or 2 50 milligram doses, and the upper useful limit of ketamine is about 200 milligrams, and I never give ketamine in the last 20 minutes of the case.
Great. Will the process EEG system also be stable with 0.5 milligrams per kilo of ketamine if we use sevoflurane instead of propofol?
Again, I would be going on my reading experience. I've never given sevoflurane, but there's a very good reason to believe from the literature that the processed EEG would be very useful, giving inhalational anesthesia as well.
Yeah, and I can help a little bit with that too. The BIS basically is monitoring the BIS, or the process EEG is monitoring the brain and how the brain is reacting to the drugs that are being given. And sevoflurane, in that sense, will work similar to propofol. So the answer from the brain will be similar. And there are a lot of clinical evidence about that. Okay, Dr. Barry, do you consider the negative immune effects also be part of the rates?
Be part of which rates?
Or rates. ORAES, yeah, the adverse effects.
It's certainly been a theoretical concern I've read about. I do know that neither propofol nor ketamine elevates markers of inflammatory response. So I think that there's a benefit of not giving opioids as well.
Okay, let's see what we have. With the current mindset regarding opioids, is this becoming the norm for anesthesia in most operating theaters? From experience as an RT in the ER, several MDs were utilizing ketamine and propofol with varying success, mainly due to individual patient tolerance.
Well, I would say that the varying success is entirely a function of measuring or not measuring the organ you're medicating. In other words, if you're not using a processed EEG to determine the patient's response, like I say, you can have patients who require as little as 2 micrograms per kilogram per minute to achieve a sedation level that you desire, and other patients who require as much as 200 micrograms per kilogram per minute. The bottom line is that you must measure to create that stable level of propofol to get the maximum benefit out of the 50 milligram dissociative ketamine dose. The other thing I can tell you is that many times people will mix the two drugs together and give them as a cocktail. It's called ketofol. That is not what I do. I don't think that you can determine that. In fact, when I talked to the people at Aspect in 1997, the only 2 papers they had with propofol ketamine were in fact ketofol or ketamine mixed with the propofol. And because the ratio of ketamine to propofol varies widely, people get widely varying responses. To be consistent, you measure, you incrementally titrate so that you get a smooth CNS level of propofol, and then you don't have any of the ketamine side effects, and you get all the good effects, which is completely to fool the brain about the body being invaded.
Great. I'm going to, several people are asking about post-operative pain. And the question specifically is, was post-op pain any different using this method? And what was the way you managed it?
Post-op pain was dramatically different, as you saw the face of that patient who had just gotten through with a 4-hour abdominoplasty surgery. There are times when additional analgesia has been requested, and very specifically when we have patients who've been lying pretty still the majority of the time, the overwhelming majority of the time, and yet when they wake up complain bitterly of post-op pain, I give them the big blue pain pills. That is the acetaminophen Benadryl combination, commonly referred to as Tylenol PM, and that the tranquilization from the diphenhydramine seems to help the effect of the acetaminophen. But that's pretty much what the post-op pain management has been, either oral acetaminophen or oral acetaminophen / diphenhydramine. And it's just, it never ceases to amaze me to watch these patients have the total body liposuctions or mommy makeovers with breast augmentation combined with abdominoplasty and have minimal pain and be able to be discharged to home without need of professional aftercare givers. It's quite an extraordinary thing to see, and it inspires cognitive dissonance, because what we know about patients, or at least what we think we know, as opposed to what patients experience in this very, very simple paradigm that's very easy to manage and reproduce, it takes you a good 10 to 20 minutes to realize, I guess this really is different, because in my first 15 years, it never once crossed my mind, why did I have to give patients opioids after surgery? Well, surgery is painful, right? And when I saw my first 50 patients wake up not in pain, who had the propofol then ketamine, it was the OMG moment. I said, gosh, this can only mean that patients are having pain during surgery, but because we don't have the ability to okay,
Hello?
that's my so clean that went off that I deliberately tried to sabotage. Sorry about
No
that.
worries. So I have a big question for you here.
Okay.
So a thoracic, open, awake thoracic procedure, would this apply to such a case?
Could you ask me one more time again?
Yeah. So let's say that I have an awake thoracic procedure.
Right.
Would you use your triad in such a patient?
The only thing I might consider doing differently is I would titrate propofol to a higher level to minimal sedation so that you can have patient responsivity. And there wouldn't be a need for the ketamine as much as there would be a need to put local anesthesia in the skin with a 30 gauge needle with buffered lidocaine, which is essentially a pretty painless way to penetrate the skin without alarming the brain. So there'd be no reason not to use this for procedural sedations.
Okay. How about the regular surgery?
Regular surgery is a wonderful thing. I have a friend who is an orthopedic anesthesiologist who only changed two things about his routine. He still gave 2 milligrams of midazolam and 2 cc's of fentanyl preoperatively, and he was giving sevoflurane. But two things he did differently was he used the processed EEG with real-time EMG monitoring, and he gave 50 milligrams of ketamine 2 to 5 minutes before skin incision. They weren't even using local anesthesia, and the patients were so dramatically different. He owned a 5-room surgery center, and the anesthesiologists from the neighboring hospital would come over and they would ask him why his patients look so much different than their patients. And gradually over the years, almost everybody at that hospital now gives what I call the nifty 50, the 50 milligrams of ketamine 2 to 5 minutes before skin incision, and they're seeing dramatically improved outcomes. So this is a pretty universal paradigm. I don't blame people if they can't give up a 100+ year tradition of giving 2 cc's of fentanyl, but they have to know that even if you're going to give antiemetics, that you're still only going to get limited utility. If the goal is to address patient satisfaction, and I think we're all into that these days, then the goal would be to stop giving the opioids.
I want to bring this comment up. It's not a question. Charles is saying that he had the Case Western CAT cut, Dr. Ralph Poritsky. Anybody in neurology and neurosciences will remember him. He says he was ambidextrous, and every student I knew went to class early to see him use 2 different colors of chalk to draw the brain before lectures. He was into ketamine in 1974 and earlier, and would love this lecture. I think that is a great comment, Charles, and I have read of Dr. Poritsky, of course, and it's a great comment. I didn't know that about his abilities. Nicole is asking, I would like to ask you if you're using any type of regional anesthesia like TAP block, Brilma, in addition to your OFA technique.
I'm wildly enthusiastic about the current generation of ultrasound-guided regional anesthesia, and I know that that involves only one needle stick to get to where you're going, as opposed to the old days when I was seeking paresthesias. So I think that the 50 milligrams of ketamine will improve all regional technique if it's given 2 to 5 minutes before skin incision after the propofol. So yes, I think regional, basically the tumescent anesthesia that we use in the subcutaneous tissues is called regional anesthesia by Jeff Klein, who created the regional, who described his tumescent anesthesia as a quote regional technique, very different from what anesthesiologists define. But I think tap blocks and leg blocks and shoulder blocks outcomes would be greatly benefited by 50 milligrams of ketamine 2 to 5 minutes pre-incision, as long as the patient is receiving the propofol measured the way I described.
Fantastic. We are on the top of the hour, actually 1 minute after, so I'm going to conclude this event, but I want to thank you very much for this great presentation. I want to thank the audience for so many good questions. If you have any questions that haven't been answered, please send them to us and we will take care of them. With that, I'm going to pass it to Tracy. Tracy, thank you very much.
Thank you, Fernando. And again, thank you, Dr. Freeberg, for such a fabulous presentation. And I wanted to mention the survey. Immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open and we appreciate your feedback. For the CE certificate of completion, to obtain your CE credits, please visit www.saxtesting.com/INIT and register on the site and complete your evaluation. And with that, we thank everyone for attending and hope you have the great rest of your day. Thank you.